Hello everyone. So hope you all are doing good. So in my last video, I have discussed about the basics of antenatal screening, its utility and implications. In today's video, I will be mainly focusing on first trimester screening, mainly the double markers and what important things you have to look at before you jump onto the ratios so as to prevent the misinterpretation of double marker reports. Very important point I would like to reiterate again and again that every single pregnant patient who visits you should undergo antenatal screening. The type, the choice may vary, but yes, you have to offer it to every pregnant patient. So very briefly, I would like to discuss with you the options of aneuploidy screening. If the patient comes to you in the first trimester between 11 to 13 weeks, 6 days, you have to offer them combined screening, which includes the NT&B scan and double marker. This double marker basically includes studies two maternal hormones, that is beta HCG and PAP-A. If she visits you in the second trimester, that is between 16 to 20 weeks, we have a triple test, which is a very old test. Nowadays, it is obsolete just because it has a very less sensitivity of around 60-70%, and better tests are available. Triple test includes beta HCG, serum estradiol, and alpha fetoprotein, and quadruple test, which has an additional marker, which is inhibin A, and it has a better sensitivity than the triple test. There is one more test, which is integrated test, which combines the first trimester and the second trimester results and gives an overall result, final result in the second trimester. We will discuss all these tests in detail in subsequent videos. And nowadays, the master of all the screening tests has come up, which is very popular among gynecologists nowadays, which is non-invasive prenatal screening. And we will be also discussing about this in subsequent videos. I am going to make a very important statement now, which is given by ACOG and SMFM, that all the screening tests, like maybe serum screening with or without NT examination, or cell-free DNA screening and diagnostic testing for chromosomal abnormalities, should be discussed and offered to all the patients early in the pregnancy, regardless of maternal age or baseline risk. That simply means when a patient comes to you, you have to discuss all the options of screening which are available so that informed decision can be taken by the patient in respect to the screening test. So now checklist number 1. Before you order a screening test, you have to look at the family history, whether there is any significant family history or not. A prior obstetric history, whether there is any history of abortion, neonatal deaths, IUD. What is the gestation age from 11 to 13 weeks, 6 days? The age of the patient, NT&B scan, which has to be done between CRL 45 to 84, and the scan should be normal. The lab selection is very important. Where you are sending the lab, is the lab fulfilling the criteria which are required for performing a double marker, and her personal history, that is an history of diabetes, smoking and hypertension. So when you include all these factors, then if the patient is falling into the low risk, you can advise her combined screening. If there is a significant history or any abnormal scan or advanced maternal age, then you have to advise her genetic counseling, and further testing can be discussed with the patient depending on the history or the scan findings. Now, sometimes some people do ask me, is combined screening different from the double marker test? So, see, double marker test basically tests your two maternal hormones, PAP-A and beta HCG. But combined screening, it includes your age risk, NT&B scan, any previous history or any high risk factor like previous baby with Down syndrome, along with biochemical risk or double marker, and this whole combines to give the to form the combined screening. So as discussed with you, the which of the following method is best for screening in the first trimester? So it could be depending on the maternal age, because we know with the advanced maternal age, the risk of Down syndrome increases. But using only maternal age as a risk factor has a detection rate of around only 30%. If we combine maternal age with NT, it has a detection rate of 75 to 80%. Only combining the maternal age with the biochemical markers, which is biochemical screening, has a only detection rate of 60 to 70%. The best or the most utilized screening test is this combined screening, which includes your maternal age, NT-NB scan findings, and both the markers, which has a detection rate of around 85 to 95%, with a 5% false positive rate, and it is a very good detection rate for combined screening. In the scan, if we combine the nasal bone, the tricuspid regurgitation and ductus venosus, the false positive rate decreases to 2.5%. But most of the softwares which use and give the combined risk, they use this method for calculating the overall risk of aneuploidies. So this is a typical combined screening report, which looks like this, where we have the pregnancy details, where we have specimen details and the actual risks. So it is a word of caution, before jumping to the just looking at the ratios, always start from the beginning, look at the pregnancy details. It will just take your 2 to 3 seconds, just have a glance on the pregnancy details. Look at the age, whether it is actually filled correctly or not, because in our country there is a difference between the actual age and the documentation age. So it should not be the Aadhaar age or some certificate age, it should be the actual age. Look at the mode of conception, whether it is IVF or spontaneous. In IVF, if it is with donor egg, it is the donor age which has to be mentioned. Okay. Then if she has a previous pregnancy with any Down syndrome or any Patau syndrome, it has to be ticked. Any history of preeclampsia has to be ticked, or if she is a diabetes, then these have to be ticked because they can alter the level of these hormones, and some correction factor has to be done in relation to these. Then coming up to the specimen details, just look at the scan date and the collection date, because the dual marker sample should be given within 3 to 4 days of doing the NT-NB scan. Okay. Then you will look at the markers. Then you should always specifically look at these marker values, whether NB is present or absent. Sometimes in the scan, anossified nasal bone is given and the risk is calculated with NB present. So there can be mismatch in the report. So always just reconfirm whether whatever the findings have been given in the scan, has the double marker, the combined screening been done on the basis of that NT-NB scan report. And finally look at these two levels of these two hormones. So in the next slide, I'll be discussing about what to look at these markers. So sometimes we get such type of reports. I usually will get these types of reports that free beta HCG is at this level, PAP is this level, and it is negative screen. So people do call me and ask, is this level normal? So I really say, sorry, I cannot remember the marker levels of each hormone at every gestation. So it's a very difficult task, and you don't have to scratch your head for this. So we never look at the absolute values. We look at a specific, these values are converted to gestation specific MOM values, which is multiples of median. So it is basically a ratio of the observed value in your patient divided by the expected value at that particular gestation. Okay. So then this is how the MOM values are calculated. And to just give you an idea where you can just have a look at the MOM values, and they should be around 1 for it to be a normal. Okay. So for beta HCG, we call it high if it is more than 2.5 MOMs, and for PAP-A, we call it as low when the values are less than 0.4 MOM values. Okay. So the particular level of these hormones are very important. So you have to look at these MOM values also, because low PAP-A can sometimes be associated with risk of FGR, preeclampsia, or bad obstetric outcome, and they need to be followed up in pregnancy for the development of FGR and preeclampsia. If a patient has very high level of beta HCGs, just rule out whether she has received beta HCG injections or not, which can falsely elevate the beta HCG values, and that can alter the risk assessment. Now, when you are looking at the levels, so just to tell you that in trisomy 21, the beta HCG is high, PAP-A is low, and in trisomy 13 and 18, both these levels, they are low, low beta HCG and very low PAP-A. Okay, so apart from looking at the ratios, if it is some high risk ratio, always make sure that you look at the factor which is giving a high risk ratio, whether it is due to the level of the hormones or it is due to the scan finding. So never ever just jump to the ratios, always interpret the details and these specimens specifically at these hormone levels and ultrasound findings. Now sometimes I get this type of report also, and clinicians do ask me ki now what, they always scratch their heads, now what to do and how to go about this type of report and which ratio we should consider and which ratio to ignore. So as we have already seen that it is the combined screening result that which looks at the maternal age, NT&B scan, the PAP-A, beta HCG, which is give you a combined risk, has the best detection rate. So we have to just look at the adjusted risk or the combined risk, which is 1:11,552 in this case. You don't have to look around at these ratios because their detection rate is very less as compared to the combined screening. Sometimes we get a result that background risk is high risk. Maternal age is around 35, 37 and it is giving you a high risk. So we already know when we have counseled the patient, we already know her age. It's going to be high if she's around 37, 38 years. So you don't have to worry about this. You have to just look at the adjusted risk, which is the combined risk and has the best detection rate. So I hope I made my point very clear. So before jumping on to the ratios, just have a quick look at the rest of the report. It will hardly take not more than 5 to 7 seconds. Just look at the history, just look at the exact age, the mode of conception, the scan findings, are these labeled right or wrong, and beta HCG and PAP-A MOM individual levels, because they can also influence the pregnancy outcome. So from now onwards, I am sure when you get a report of combined screening, before jumping on to the ratios, you will just have an eagle's eye view on rest of the details for make the interpretations very easy and clear. And in my subsequent videos, I'll be discussing on small these points on antenatal screening, which will make your life very easy and comfortable. So if you like my videos, please subscribe and share among your friends also, so to increase the awareness about antenatal screening. Till then, stay tuned. Namaste. Thank you.